Thank you very much for this illustrative presentation, as usual. And now we ask for Professor Samer Koussayer. Will talk about a case of CAA or CAS in asymptomatic carotid stenosis, when to do it.
Good afternoon. Yeah, I'm speaking about the case for CAA or CAS in asymptomatic carotid artery stenosis. This is a very nice paper published recently. They look at the natural history of asymptomatic carotid artery stenosis in the era of medical therapy. And they found the incidence of carotid stenosis progression in asymptomatic carotid stenosis was high even with the use of aspirin and statin. This is also a nice paper. They look at the patient who come to the hospital with a stroke, and they found 7% they already have an asymptomatic carotid artery stenosis, more than 50%, in spite of the patient being on antiplatelets, statin, or both. So what they conclude that medical therapy alone is unlikely to be sufficient stroke prevention for patient with significant asymptomatic artery stenosis. This is also a nice paper. They look at association between asymptomatic carotid artery stenosis and cognition dysfunction, and they found the ACAS associated with the impaired mobility and cognition that are accompanying with increased fall risk. This impairment increased with the increased severity of ICA stenosis. So what the guidelines tell us, we have two major guidelines now. We have from European and from United States, and both are new guidelines. Let's start with the European guideline regarding asymptomatic carotid artery stenosis. If the stenosis is 60 to 90%, they recommend a life expectancy more than 5 years, favor anatomy, and you have more one than features suggest higher stroke rate on BMT. They recommend to do CAA or CAS. What do they mean by high risk? That means you have contractile TIA or stroke, ipsilateral silent infarction. On ultrasound imaging, you see a stenosis progression, spontaneous embolization on transcranial Doppler, impaired cerebral vascular reserve, large plaque, equiescent plaque or hypoechoic plaque, or you see intraplaque hemorrhage or lipid-rich necrotic core on MRA. Then what about the American guideline, the SVS? The SVS depend on two major trials. They depend on ACAS trial, which is American trial, 1995, and then we have an update on this one, 2004, and the ACAS trial and ACAS-1 trial, which is a European trial. If you look at the ACAS trial, it's an older trial. It's 5 years follow-up. They have more than 1,600 patients, and they compare medical with a treatment versus carotid endarterectomy, and they found there's no difference between two groups in the incidence of major stroke or death. But the incidence of any ipsilateral TIA or stroke or death was lower in the surgical group. So what they conclude that CAA reduced the risk of any stroke or death from 11 to 5% at 5 years in patients with asymptomatic carotid stenosis, more than 60%, with a reduction of about 53%. And the ACAS recommended that CAA for patients aged less than 80, as long as the expected comorbidity combined stroke and mortality rate less than 3%. Then we have ACAS trial. Also, they have more, it's a randomized control trial, more than 3,000 patients with 5 years follow-up, and also showed an advantage in limited stroke and death at 5 years for CAA compared with the maximum medical therapy, 4.1 versus 10%. So they look at 5 years risk for all stroke and fatal or disabling stroke. The CAA group was reduced by half compared with the CAA deferred group. Then we have a follow-up on this trial about 10 years after that, even 15 years. And even after 10 years, we still see CAA showed a benefit for asymptomatic carotid stenosis with a reduction from 17.9 to 13.3, was again about 4.6%. Half of this reduction was in disabling or fatal stroke. What about lipid-lowering medication? Because many people, they can criticize these trials because they said that this trial, they were not taking statin. But if you look at the ACAS-1, it showed that stroke risk with a CAA plus medical therapy was half that on MT alone, irrespective of patient taking statin or not. So the annual reduction was 0.7 versus 1.3 annually for patient on lipid-lowering medication, whereas 1.8 versus 7.3 annually for patient not on lipid-lowering drugs. So if you take a statin, this will lower your risk of stroke, but still if you combine with a CA, still showed that CA give you a benefit even if you are on statin or not on a statin. Also in another paper, they look at the best medical treatment alone may not be enough for asymptomatic carotid stenosis. This is from Conrad. He found that BMT failed to prevent carotid stenosis progression in 40% of patients with ACAS and development of epicyclic neurological symptoms in 12%. Also, not patients with ACAS carry the same risk factors. Also, not all asymptomatic patients are really asymptomatic because patient may get a TIA where he's sleeping. When he wake up, he is fine. So we label it as asymptomatic even though he's symptomatic. The second thing, there's an evidence that cognition dysfunction improve after CA or CAS, but there is no improvement with BMT. So all this led the society, and we are lucky here to have Dr. Abu Rahma, Professor Abu Rahma, to talk about it more in details. They give us a strong recommendation, grade 1B, in low surgical risk patient with asymptomatic carotid stenosis, more than 70%, they recommend CA with best medical therapy over medical therapy alone. But to get this benefit, really, this is a long-term investment. The patient has to live at least 2 years. And the most important, your operative stroke and death rate should be less than 3%. Then we have an Oxford Vascular study. It's a prospective population-based cohort study. And they correlate between epicyclic stroke and degree of asymptomatic carotid stenosis. Treated with contemporary best medical therapies. They have more than 2,000 patients. And they found that epicyclic stroke rate at 5 years for patients with 70 to 99% was 14.6%, whereas 0 for patients less than 70%. And even this one more pronounced if your stenosis go 80 to 99%. So what they conclude, the stroke risk was high, dependent on the degree of asymptomatic carotid artery stenosis, and the benefit of CA was cleared for patients with severe stenosis 70% and above, and mainly for 80 to 90%. So who should get really the CA for asymptomatic carotid stenosis? It depends on the degree of the stenosis, especially if you have high-grade stenosis like 80 to 90%. If you see a progression of the severity of the disease, like more than 20%. If you see if patient has asymptomatic embolization detected by transcranial Doppler ultrasound, if patient has ipsilateral silent embolic infarction on CTA, or had carotid plaque morphology, which put this plaque on the high risk, or if he has a reduced cerebral blood flow reserve. What about stenting? If you look at the ACAS-2 trial, which look at the stenting comparing with the CA, they found the 3-day rate of death or any stroke was high for CAS compared with the CA. But if you look at the 5 years, there was no different. Then we have 2017, we have meta-analysis of major 5 trials, and all of them, they showed the peri-procedure stroke was higher for CAS comparing with the CA, but peri-procedure and ipsilateral stroke during long-term follow-up was similar, and the composite outcome of this stroke or MI was also similar. Also, this is a nice paper. They compared TCAR with the CA and transfemoral CAS, and they found TCAR is very comparable to CA, but has less chance of cranial nerve injury, but it's much better than transcranial transfemoral CAS. So conclusion, patient with more than 70% asymptomatic carotid artery stenosis should be considered for CA, TCAR, or transfemoral CAS to decrease the long-term risk, but at least the patient has to live 3 to 5 years, and the most important, perioperative stroke and death should be less than 3%. Determination which technique based on the presence or absence of high-risk criteria for CA, TCAR, or transfemoral CAS. Upcoming randomized trial hopefully will answer more study about the best management for asymptomatic carotid artery stenosis, like SPACE2 and CRISP2. Thank you very much.